All right, in this lecture, we're going to talk about a very high yield topic, pulmonary embolism. So this can be pulmonary, we could discuss it in hemonc, um, a lot of different kind of overlapping features. We'll talk about a lot of the etiologies. So really it can kind of span across all of internal medicine. So objectives wise, we're going to define pulmonary embolism. We'll talk about common risk factors. We'll discuss Furcow's triad, other risk factors that aren't discussed in that section. We'll do the Wells score and the PERC score. We'll talk about those. Workup management. We'll talk about submassive versus massive PEs and kind of how the management changes with regards to those. We'll talk about something called the Pulmonary Embolism Severity Index, and then we'll do a putting it all together. Like I said, for the sake of like step exams, you will get a question on PE, or at least a question where you have to kind of rule out PE. You will also commonly see this right when you're on the wards. Either a patient is presenting in the ED with signs and symptoms of a PE, or you have a patient on the wards who develops a PE. So very high yield concept. So a case for us to consider. We have a 26-year-old female. She presents to the ED with complaints of fever, dyspnea, and pleuritic chest pain. She noted the chest pain and fever started this morning, and shortly after getting out of bed, she felt short of breath. She denies any cough. She notes 2 weeks ago she was started on estrogen-based contraceptive and denies any history of immobilization, long travel, or recent trauma or surgeries. She notes her mom has a history of 2 DVTs and is currently taking some medication for it. EKG is obtained and shows sinus tach. Chest x-ray is unremarkable. Her vitals are notable for a heart rate of 110. BP is 115 over 82. Respiratory rate 25 and an SpO2 of 91%. So I want you to think about what is your next best step in management. Should we start ceftriaxone and azithromycin? Should we start IV methylprednisone? Should we check for factor V Leiden mutation? Should we start unfractionated heparin? Should we start warfarin, or should we do a chest CT without contrast? So pause your screen and think about it, and then we'll discuss the right answer. So obviously, right, this is a case on pulmonary embolism, right, because the whole lecture's on it. She has quite a few signs and symptoms of PE that we'll kind of talk about as the lecture progresses. But whenever you see, right, dyspnea, pleuritic chest pain, tachycardia, tachypnea, hypoxemia, right, those are all kind of pointing me towards a potential PE, right? Those could be signs and symptoms of other kind of things, other diagnoses that you want to consider for like a differential when you think about dyspnea. But the fact that all of them are together, and then we have this young female who was recently started on estrogen-based contraceptives, which we'll talk about why that's important in a second. Those are other sign like things that kind of increase the likelihood ratio that this is likely a PE. So whenever you have a patient who is kind of concerning for a pulmonary embolism, we have to do what's called risk stratification. And we'll talk about some of the methods we can do to risk stratify coming up in this lecture. The most commonly used one is called the Wells score. And we'll talk about that again as we move forward. But for a patient who has a high Wells score, right? And basically, for now, all I want you to think about, do you think this is a slam dunk PE or not, right? If it's a slam dunk, right, this patient recently started on estrogen contraceptives. She has a fever, low-grade fever, dyspnea, pleuritic chest pain. She's tachycardic. She's hypoxemic, right? This is very concerning for a PE. For someone who has a slam dunk PE or very high concern, there's a couple things we need to do. First things first, we got to start them on anticoagulation, right? The gold standard for anticoagulation for a submassive or a intermediate or non-life-threatening PE would be unfractionated heparin, right? Unfractionated heparin is going to work now. Remember, this works by modulating antithrombin 3, and it will block factor 10 directly, and then via electrostatic binding, it blocks factor 2, right? So that's thrombin. So an unfractionated heparin works very quickly, and it's very titratable, so we can turn it on and turn it off, right? If we need to do some sort of surgical procedure that we could talk about later as we get into like the massive PEs. And I want you to think about, right? Think to yourself, if I needed an antidote, if the patient for some reason got too much heparin for whatever reason, what's the antidote for heparin overdose? So that's going to be protamine sulfate, right? Just kind of integrating a little bit. So first things first, right? If the patient has signs and symptoms that are very concerning for a PE, we can start unfractionated heparin without even getting imaging, right? Because unfractionated heparin, let's say we get imaging and all of a sudden now we're like, maybe it's not a PE. We can turn that off, okay? But really, you'll see this in UWorld, AMBOSS, MBME. If signs and symptoms are very concerning for PE, unfractionated heparin should be started while you're wheeling them down to the CT scanner, okay? So to definitively diagnose PE, and again, we'll talk about this coming up, our gold standard is going to be a CT pulmonary angiogram. If the patient can't do a CT pulmonary angiogram, a VQ scan is also an appropriate option. And again, we'll talk about that in a little bit. If we look at our other answer options, start ceftriaxone and azithromycin. Those would be great options for a patient who has community-acquired pneumonia, right? Pneumonia, by definition, is infection of the pulmonary parenchyma with a new infiltrate seen on chest x-ray, right? This patient does have a fever, right? They have pleuritic chest pain, both signs and symptoms of potentially a pulmonary infection. There's nothing seen on chest x-ray. This makes it less likely that this is pneumonia, less likely needed to start ceftriaxone and azithro. Methylprednisone, right, would be a great option if this were some sort of inflammatory disease, right? A lot of our vasculitis, even lupus, all those kind of rheumatological diseases can absolutely cause pulmonary infiltration and parenchymal disease and pleuritic chest pain, right? Pleuritis, pericarditis even, and methylprednisone would be a good option, right? I don't see anything here about arthralgias, myalgias, new rashes, right? If we were thinking about something like pulmonary renal syndrome, we would have to see something about some abnormalities in the urine, like increased protein or red blood cell count. We don't see anything here that would really point to some sort of systemic rheumatological condition, right? We could even get into like the sclerosis type diseases where, your patient could have calcinosis cutis, Raynaud's, esophageal dysmotility, sclerodactyl, telangiectasias. We don't see any of that. No need for methylprednisone. Factor V Leiden, right? We're going to talk about this in a second. This patient may have factor V Leiden. They might be homozygous. They might be heterozygous, right? The mom has a history of DVTs, multiple DVTs, right? And this patient was started on estrogen-based therapy that kind of kicked off a hypercoagulable state, right? I'll show you the data in a second about why that should key you in on potential thrombophilia. So eventually, we're probably going to do a workup for factor V Leiden, prothrombin gene mutation, probably like a protein C, protein S deficiency, antithrombin 3 deficiency. We'll do a whole thrombophilia workup probably, but that is not the most appropriate next step, right? Most appropriate next step is to start anticoagulation to kind of destroy this thrombus that's likely in the pulmonary artery, get imaging to confirm, and then treat. And then as an outpatient, we can do the thrombophilia workup. Starting warfarin, remember warfarin is my vitamin K antagonist. It blocks VCORC, right? VCORC is really important to cause gamma carboxylation or to reduce vitamin K into its reduced form. And then that reduced form of vitamin K is used for gamma carboxylation of factors 2, 7, 9, 10, protein C, and protein S. Warfarin is a good option for long-term anticoagulation, although it's kind of falling out of favor for a lot of different diseases now due to the great use of DOACs, right? Like myopixaban, rivaroxaban, those kind of drugs, right? Talking about warfarin would be a story for a whole nother day. The reason this is the wrong answer is warfarin is pretty slow to work. It takes a couple of days for it to really kick in. Would not be a good option now, right? You would have to also bridge with heparin or at least another anticoagulation agent, which is most commonly heparin that's used to bridge, because we get worried for warfarin-induced skin necrosis or thrombosis, right? Which is a story for another day. And then chest CT without contrast, right? Not appropriate. If we were concerned for PE, which we are, we need to do pulmonary angiography, right? With IV contrast, looking at the actual pulmonary vessels. So chest CT without contrast, not appropriate here. So that's all outlined here. I'll keep it on this screen if you guys wanted to kind of read a little bit more about what I wrote. But that's all in there. So a brief aside on the OCP-induced venous thromboembolism, right? A lot of information here. All I want you to get out of this, right, is that the American Society of Hematology kind of outlines this. Whenever I think about a patient who has recently started on combined oral contraceptives, who then develops some sort of thromboses, you want to think about underlying thrombophilia. The underlying thrombophilia may be kind of sitting dormant, if you will, right, to kind of conceptualize it. And then when I give the patient this new estrogen-based compound, it kind of kicks things off. And so you can see I outlined like a lot of the data. Knowing these numbers isn't super important. What is important, right? My takeaway is maybe consider a thrombophilia workup if a patient presents with VTE after starting some sort of estrogen-based contraceptive. Because the estrogen-based contraceptive plus the thrombophilia is going to kind of kick them over the edge into this thrombotic state. So I want to think about what is a pulmonary embolism. So our definition, right, it's going to be a blockage of a pulmonary artery or one of its branches by a clot, right? Where's that clot coming from? It's most likely coming from a deep vein thrombosis, right? Kind of my big veins in my lower limbs, right? What happens is those clots embolize out, they move up, they make it their way to the inferior vena cava, they make their way into the right side of the heart, and then will get stuck as they're moving through the pulmonary arteries and some of the smaller branches, right? Depending on how big that clot is, right? If it's a massive clot, it could block the big old piece of the pulmonary artery that's just branching off of the right ventricle. So common signs and symptoms that should key you in: sudden dyspnea, pleuritic chest pain, right? Because we're going to get inflammation of the parietal pleura and potentially the visceral pleura as well, right, surrounding the lungs. So pleuritic chest pain is any kind of pain that is exacerbated by inspiration, right? Because I inspire, it's going to push my pleura against my chest wall, and the inflammation will get irritated and it will cause the patient pleuritic chest pain. Pleuritic chest pain is by no means specific to PE, but it's just a common thing you might see. Tachycardia, right? This is an extremely inflammatory situation. The whole body is going to be in a sympathetic overdrive. You'll see tachycardia. You'll see tachypnea, right? The respiratory rate will increase. You may see hemoptysis as well, right? Some of this inflammation, right? We're going to have some leakage of blood that's going to kind of diffuse into the alveoli, and then the patient is going to cough up some of this blood, right? And then we could potentially see syncope as well. If we get a massive PE that is cutting off complete flow from the right side of the heart to the left side of the heart, right? Because obviously blood flows from the right ventricle through the pulmonary vessels into the left side of the heart. So now my left side of the heart is not receiving as much blood. There's less blood making its way up through the internal carotid arteries, less blood perfusing my circle of Willis, right? The patient could undergo syncope, right? A transient loss of consciousness. So syncope would be a horrible sign in a patient with PE, right? But it's something you got to consider. So again, the combination of these signs and symptoms should all key you in on PE. And I think that the key here is it's a sudden onset, right? Most of the time, there is something called chronic thrombotic embolic pulmonary hypertension, right? CTEPH, which is the fourth type of pulmonary hypertension, which is where you get small little clots that kind of build up over time in the pulmonary vasculature, and that can lead to right-sided heart failure. That's a chronic process, right? An acute pulmonary embolism is when we get an acute blockage of one of these vessels that then leads to these signs and symptoms and potentially devastating complications with regards to the right side of the heart and perfusing the rest of my body, right? A full-on obstructive shock. So why this matters, right? We can get VQ mismatch, right? In breath, right? VQ could be a whole lecture for itself, but right? We ventilate, we breathe in oxygen through our mouth, right? Through the oral pharynx and the trachea. We make our ways down through the small little bronchi and then the bronchioles, and then we make our way to the alveoli, right? The alveoli are then in contact with pulmonary vasculature, right? The pulmonary capillaries. And inside those pulmonary capillaries are my hemoglobin molecules, right? And in the hemoglobin molecules, right, we give oxygen and we remove CO2 and then we breathe out CO2. So that right there, the alveoli capillary membrane is super important for understanding VQ match and mismatch, right? So the V part is the ventilation. Am I able to get oxygen through my oral pharynx or trachea down to the alveoli? Is that okay? And then the Q is perfusion, right? Am I able to perfuse my vessels so that there's enough of my blood flowing through so that when I'm breathing in the oxygen, the alveoli can undergo gas exchange appropriately? So in a patient with PE, it's the perfusion that's mismatched, right? Let's say the patient is totally healthy otherwise, they're able to ventilate their alveoli totally fine. But in this case, we're cutting off blood supply to some of those alveoli. So the Q is going to be really low. Their V should be normal. Okay. In opposite, right, if you have a patient with the V is the problem, right? So that would be like an example. V, when V is the problem, we call it shunt. When Q is the problem, we call it dead space, right? So in this case, we have a lot of dead space because we're ventilating parts of my lung that aren't perfused. And so when the V is a problem, we call that shunt, right? And in this case, you could have things like a big malignancy, pneumonia, any kind of interstitial lung disease, anything that's messing with the alveoli, right? COPD, things along those lines. And in that case, right, you can have hypoxic pulmonary vasoconstriction, right? The lungs are a very smart organ. And when we're not perfusing a certain part of the alveoli appropriately, or when the alveoli are not ventilated appropriately and we're perfusing totally fine, your lungs are like, hey, we need to start perfusing parts of the lung that are actually going to undergo oxygen transport, right? So the way I think about it is you have two alveoli, right? Obviously, we have millions, if not billions and trillions of alveoli. But if you just think about it, we have two alveoli. One of them is working totally fine, and one of them is got like severe pneumonia, and we're not able to ventilate that entire lung, right? So what your lung is going to do is it's going to cut off blood supply to the bad alveoli, and it's going to shunt blood all over to the good alveoli to try to maximize VQ mismatch, or the VQ mismatch in this case. For the sake of PE, that's not really happening here, right? The PE, we have a perfusion problem where we're cutting off blood supply. Okay, so we have to remove that perfusion problem. We have to remove the clot to improve blood supply. And again, right, if the clot is bad enough, we can cause right ventricular strain, right? The right ventricle is a pretty weak kind of muscle. It can't pump as hard, right? Against increased afterload. The pulmonary vascular resistance is sky high in a patient with a massive PE. So the right ventricle has to pump, pump, pump even harder, and eventually it kind of gives out. We're not able to commit to forward flow. Fluid backs up. We get right ventricle dilation, atrial dilation, fluid backs up. Eventually you can get JVD, manifestations, jugular venous distension. You can get hepatomegaly, right? This would be more of like a chronic picture, but these would all be signs of impending obstructive shock. All right. So Virchow's triad, right? Remember the three aspects of Virchow's triad are hypercoagulable state, endothelial damage, and venous stasis. So really, after we're done kind of acutely treating the pulmonary embolism, we have to ask ourselves why. Why did this patient have a pulmonary embolism, right? That's your job as the internist, right? It's to always ask why. So just stopping at treating the PE is not appropriate. If you don't understand the why, this patient could be at risk for another PE, right? And the next one could be deadly, right? So we have to figure out what's going on there. And so if you understand Virchow's triad, it gives you a nice little framework to kind of think through what are the possible causes. These are some of the major risk factors that tend to show up on step exams and in real life, right? So recent surgery or immobility, right? When the patient has a big surgical procedure, ton of inflammation, your body's going to release a lot of thromboplastin, which is tissue factor, right? Tissue factor is also factor 3, which kicks off the whole extrinsic pathway, right? So factor 3, then factor 7, 10, 5, 2, 1. So we get overactivation of the clotting cascade. Cancer, right? Cancer is an extremely hypercoagulable state. The classic step question, you'll have a patient with a PE or a DVT, you rule out all the big stuff, and you're like, well, what the heck caused it, right? You should do age-appropriate cancer screening to kind of rule out, do they have an underlying cancer? They might hint at in the question, they have weird abnormalities in their CBC, they have enlarged lymph nodes somewhere. Maybe they've been pooping out blood, right? Colorectal cancer, all things you can think about, right? The biggest risk factor is going to be actually a prior VTE, right? If they've had one, they're at risk for another one. Estrogen, and we'll talk about the mechanism of estrogen in a second as to why that causes a hypercoagulable state. But estrogen or combined oral contraceptives, pregnancy and postpartum, right? Pregnancy, obviously the estrogen is very high, and we'll talk about that mechanism. But postpartum, right? You always want to think about when in a postpartum patient, right? Their hormones are still out of whack, and it takes a while for them to kind of make its way down. pregnancy in itself, like when the woman goes through actual birth, right? An extremely inflammatory state, right? So all these things can predispose. So you want to be on the lookout in a vignette or in real life of a patient who recently gave birth, right? Who is now also at risk for this hypercoagulable state. Thrombophilia is right. I have a whole lecture on thrombophilia. So go look at my heme onc section. But those would be like factor V Leiden is the most common, right? You think about them in like white European individuals. You have the prothrombin gene mutation, antithrombin 3 deficiency, things along those lines, right? Factor V Leiden being the most common. I'll just talk about it quick, right? Normally, protein C and protein S kind of form a compound together and they inhibit factor V and factor VIII, right? And that kind of slows down the clotting cascade. In factor V Leiden, these patients have a gene mutation where the factor V protein no longer kind of responds, or it doesn't respond as well to the inhibition by protein C plus protein S, right? So the clotting cascade kind of persists. And then one of the ones that kind of gets forgotten about is nephrotic syndrome. So remember, in nephrotic syndrome, we have underlying damage to the glomerular basement membrane and the podocytes. We're leaking out protein in their urine. Remember, to make the diagnosis, we classically think about 3.5 grams of protein in the urine per day. With regards to this, we're not just losing albumin in the urine, we're losing things like immunoglobulins, so the patient's at risk of infection, and we're losing things like antithrombin 3, protein C, protein S, which puts the patient at a hypercoagulable state because we're losing those anticoagulant proteins, right? They'll give you something in the vignette about the patient maybe being edematous, right? They have periorbital edema, they have pitting edema bilaterally, right? And then they'll tell you we got a UA, the UA showed 4+ protein, right? That's when you kind of think about it. And another thing is, right, these patients tend to have, especially like long-term nephrotic syndrome, they tend to have elevated cholesterol levels. And in this case, right, your liver is we're losing all this albumin, and the liver's trying to keep up with making more and more albumin, but eventually it kind of putters out, and the liver's like, well, we got to do something to increase this oncotic pressure. And one thing it does is it increases the production of certain cholesterol molecules to try to increase the oncotic pressure a little bit in the system, right? So these patients may have a significantly elevated cholesterol. That could kind of key me in on that diagnosis. So why does estrogen cause a hypercoagulable state? It's quite simple, actually, right? So it increases the procoagulant proteins and it decreases the natural anticoagulants, right? So it increases things like fibrinogen, 2, 7, 8, 9, 10, 12, right? And then it decreases my anticoagulants like protein C, and then it kind of causes like a protein, it lowers protein S, and then it causes a protein C type resistance. It's almost like factor V Leiden. So increases procoagulants, decreases my anticoagulants. It also increases plasminogen activator inhibitor, which will kind of decrease the ability for me to break down clots. So remember, plasminogen gets converted into plasmin, and plasmin is what converts or breaks down fibrin into smaller little products, so we break down the clot. If we increase the plasminogen activator inhibitor, we're not able to make as much of my plasmin, so the clot persists longer. So the net effect, right? Increase procoagulants, decrease anticoagulants, decrease fibrinolysis. The clot persists longer, right? We're in a hypercoagulable state. That's kind of what estrogen is doing from a biochemical perspective. So how do we stratify? Does this patient have a PE? Do we not know, right? The common one is the Wells score. There's also something called the Geneva score, which I don't go into here because I think the Wells score is more like commonly used. There's been like a back and forth in the literature. You know, you might see like values of like 6 as a cutoff. You might see values of 1 as a cutoff. You might see values of 4 as a cutoff. If you look in the literature, as of right now, a score of 4 is kind of the consensus cutoff. So if the patient has a Wells score of 4 or more, that makes a PE quite likely, or at least it's very highly likely, right? If the score is less than 4, it's maybe less likely, right? And here's how we calculate the Wells score here. You can just use it on MD Calc. I definitely don't think this is something you have to necessarily memorize. But you do enough of these questions, you do enough reading, you kind of just understand, okay, like these are all signs and symptoms of a PE. My clinical gestalt is pretty high right now. My vibes are saying it's a PE, right? So clinical signs and symptoms of a DVT gets you 3 points. PE is the number one diagnosis or equally likely gets you 3 points. Heart rate of 100 gets you 1.5. Immobilization or surgery gets you 1.5. Previously diagnosed PE or DVT gets you 1.5, and hemoptysis and malignancy each get you 1 respectively. So again, if that score is above a 4, we're like, this might be a PE, right? If it's less than a 4, maybe less likely. And we'll talk about what we do with that in a second, right? If the patient has a score less than 4 on the Wells score, we can do something called the PERC score. So essentially what the PERC score does is when the patient has an unlikely Wells score, I go and I look at their PERC score. And if their PERC score has anything that's positive, right? There are 8 things here. If anything of them are positive, the literature says we should get a D dimer, right? If they're all negative plus a Wells score that's unlikely, then hey, maybe I don't need to do any workup. It's probably not a PE. So essentially, right, my workflow would be patient comes in with X, Y, or Z, and I'm like, all right, let me order a well, or let me work up and do their well score, right? Their well score comes out to be like a 3. And we're like, okay, maybe not a PE, maybe it's not everything's there for me to kind of like be really strongly considering and start a unfractionated heparin and go do a CTPA. So their well scores are 3. I go and I do their PERC score, and their PERC score ends up being 0, right? They're not over 50, their heart rate's not over 100, their O2 sat is above 95, they don't have any leg swelling, there's no hemoptysis, no recent surgery or trauma, no prior PE or DVT, and they're not on any hormones, right? So if that PERC score is 0, I'm now pretty consistent with, okay, this is probably not a PE, I should start looking elsewhere, right? But let's say their well score was 3, and I did this PERC score, and even just one thing, right? The patient's 51 years old, okay? If that's the only thing that's positive, I should get a D dimer, right? And if that D dimer is elevated, okay, PE still on the differential, right? D dimer is a very sensitive marker for PE. It is extremely non-specific, right? D dimer can be elevated in a million things, right? So if the D dimer is elevated, I say, okay, PE still on the table. Let me go get a CTPA, right? The gold standard diagnosis, okay? If the D dimer is normal, within normal limits, or it's low, right? Or it's not elevated, we can be pretty certain, okay, this is not a PE, and we look elsewhere, okay? So D dimer, very sensitive, right? So essentially, like I like to think about it in the terms of lupus, because everyone loves the lupus antibodies, right? If ANA is positive, that means lupus is still on the table. But then I need to go get more specific antibodies, things like anti-double-stranded DNA, anti-Smith. And if those come back positive, I can be fairly certain, right? There's probably like this patient probably has lupus, right? If the anti-Smith and anti-double-stranded DNA come back negative, okay, maybe it's not lupus, right? And if the ANA is negative to begin with, it's not lupus, right? It's a highly sensitive antibody, right? So sensitive are good for ruling things in, specific are good for ruling things out. So essentially, with regards to the PE, if the D dimer is elevated, the PE is still on my differential. If the D dimer is not elevated, maybe look elsewhere, okay? All right, so the workup, right? First things first, is the patient stable or unstable, right? This is gonna kind of, we'll talk about like massive and submassive PE in a second. But if the patient is unstable, right, meaning their systolic blood pressure is less than 90, they have severe hypoxemia, altered mental status, this is very concerning for obstructive shock. We're gonna need to send them to the ICU, and we're gonna need to act ASAP, right? If they are more stable, right, then we can kind of go on to the next steps, right? So things we would do first, you get your airway, breathing, circulation, right? You look at their O2, we make sure we get IV access. We can do an EKG and a bedside echo to look for right ventricular strain, right? We can look for right atrial dilation, right ventricular dilation, all things that kind of point me towards, okay, this is a massive PE, okay? Which again, I'll define in a second. For then, like, so let's say, okay, they're stable, we can move on, right? So we have to kind of help look at our differential diagnosis, right? Because the differential diagnosis for pleuritic chest pain, tachycardia, low-grade fever, tachypnea, it's quite wide, right? So we look at the vitals and the pulse ox. we can get an EKG, right? The most common EKG finding in a patient with pulmonary embolism is not that S1Q3T3, where we see a nice S wave in lead 1, a nice Q wave in lead 3, and an inverted T wave in lead 3, right? That's classically what you'll read, or maybe you saw it on an Anki card, but that's like less than 10% of patients. You'll see the S1Q3T3. What we see in like 90% of the patients with PE is just sinus tachycardia, okay? But getting the EKG, it can help us rule out a STEMI or NSTEMI. It can help us rule out pericarditis and kind of other things along those lines that could be manifesting as this chest pain. We could get a chest x-ray that could show us a pulmonary infiltrate that might key in on pneumonia, pneumothorax, pulmonary edema. Remember, like in chest x-ray, you could potentially see a Westermarck sign or Hampton's hump in PE. Again, those are very, very, very rarely seen. So again, most of the time, you're just going to get a normal chest x-ray in a patient who has a PE. Labs, we could get a CBC, a CMP, PT, INR, PTT, a pregnancy test, right? And then cardiac markers, we should get troponins plus or minus a BNP, right? So pro-NT BNP being elevated could key me in on some sort of aspect of right heart strain, as could a troponin as well, right? Troponin being elevated is not just a sign of myocardial ischemia, right? It could also be a sign of ventricular dysfunction and kind of build up there. That is a story for another day, but elevated troponin by itself is not indication of myocardial ischemia at its core, right? So all things to consider. So then we kind of think about our pretest probability, right? So this would be good to kind of go over again. I've already explained it once, but we can use the Wells score, the revised Geneva, that kind of puts us into the low, intermediate, or high, right? If it's a low risk, right? So the Wells score is less than 4, we can apply the PERC, right? If the PERC is negative, meaning none of those 8 tests or none of those 8 values come back as a yes, they're all no's, then we don't need to do a D-dimer. We don't need to do an imaging. We just clinically ruled out a PE. If we have a lower intermediate suspicion and the PERC is not completely negative, meaning at least one of those 8 questions we answered yes, let's get a D-dimer. If the D-dimer is negative, we can rule out a PE. If the D-dimer is positive, let's go get a CTPA or a VQ scan, okay? If there's a high pretest probability, right, the Wells score is above a 4, skip the D-dimer and go straight to imaging, right, CTPA or VQ, right? So here's the imaging, right, CT pulmonary angiogram is the first line test, okay? That is the gold standard to diagnose a PE as of right now. We can do a VQ scan if the patient has a contrast allergy, they have significant renal issues, or they're pregnant, okay? We try to shy away from a VQ scan because it's not the best test here. Obviously, it can still be used and in these certain situations, right? So really, like when you're answering a step question or in real life, you just have to ask yourself, can this patient undergo a CTPA, right? Big no's would be really bad contrast allergy to the iodine, really bad renal issues where this could exacerbate contrast-induced nephropathy, or they're pregnant, right? Those would be times to do a VQ scan. Technically, we could do compression ultrasound of the legs. That would never be the first step, right? Because they'll probably have a clot somewhere in the legs. Me showing they have a clot somewhere in the legs doesn't really help me make the diagnosis of PE, right? But it could kind of just add to the clinical picture. We start anticoagulation when appropriate. If the suspicion is high and imaging will be delayed, just start that therapeutic anticoagulation while we try to go get the imaging. All right, we've kind of talked about that. So PE categories, right? We've kind of alluded to this, right? Going low to high, we have a low risk PE where the patient is normotensive, right? Their blood pressure is totally fine. There's no right ventricular strain, and they have normal biomarkers, right? So that would have been our patient in the clinical vignette to begin. Submassive or intermediate risk, right? They're still normotensive, but now there's signs of right ventricular strain, either on the CT or an echo, and maybe they have elevated troponin and BNP, which tells me there might be right ventricular dysfunction going on. And then there's massive or high-risk PE, where they're hemodynamically unstable. So they have shock, sustained hypotension, right? So the SPP is less than 90, or they drop greater than 40 millimeters of mercury for over 15 minutes, and then they need vasopressors or they have a cardiac arrest, right? So this is the the way I think about it, right? My patient has a PE, or they have signs and symptoms concerning for PE. The first question you need to ask is stable or unstable, right? Look at that blood pressure. Is the systolic above 90? If yes, okay, most likely stable, right? What's their mental status, right? If it's less than 90, okay, now I'm a little bit concerned, right? Right ventricular strain also plays a role, but that blood pressure is going to be kind of the key thing we go off of, right? So low blood pressure, so hemodynamic instability plus right ventricular strain, we're like, okay, this is massive, and it completely changes my management, right? Blood pressure being 120 over 80 with no right ventricular strain, okay, we can do unfractionated heparin and CTPA, okay? All right. So management, right? Risk stratification. I literally just talked about this. We'll talk about the PESI score in a second. So high risk, okay, it's massive. We need to do immediate anticoagulation and reperfusion. So in a patient who has this high risk, massive PE based on systolic blood pressure less than 90 and right ventricular strain, we're going to do systemic thrombolysis, right? So that would be like your tissue plasminogen activator, right? Your TPA, TNK, those kind of guys, right? If the thrombolysis is contraindicated, which we'll talk about kind of like contraindications for thrombolysis in a second, we can do what's called catheter-directed therapy or surgical embolectomy, where essentially we're sticking a catheter in and we're putting the TPA directly into where the clot is, or we're surgically removing the embolus, right? Systemic thrombolysis is first line because it's easy. We can give it, but some patients have contraindications to TPA, and so we'll talk about what those contraindications are. If it's an intermediate risk, right, so submassive, we'll do anticoagulation and close monitoring, and if they start to deteriorate, we'll do the rescue thrombolysis or catheter therapy. If it's low risk, right, anticoagulation, and they could potentially be early discharge and outpatient, right? But again, right, I think a lot of students know for PE, it's like unfractionated heparin, CTPA, and then you monitor. What they don't know is if your patient is hemodynamically unstable and they have right ventricular heart strain, and we're thinking, okay, now this is a massive PE, the unfractionated heparin is not going to cut it. We have to do systemic thrombolysis, okay? Systemic thrombolysis, and if that's contraindicated, then we would do catheter-induced or catheter-directed lysis or surgical embolectomy, okay? So systemic thrombolysis contraindications, right? The absolute ones are prior hemorrhagic stroke, ischemic stroke within the last 6 months, if they have underlying CNS damage or an intracranial neoplasm, major trauma, surgery, head injuries within 3 weeks, GI bleeding within the last month, or known major risk of bleeding. Okay. Here's some of the relative contraindications. I'll let you kind of just take a look at those. Really in a massive PE, I'm just considering these absolute contraindications, and some of the submassive, or in like some of the submassive, we wouldn't even really be considering thrombolysis, right? So it's really at the discrepancy of the treating clinician. I think for the sake of like step 2, especially, they're probably not going to give you any of these contraindications, and they just want you to know if the patient has a massive PE, we should treat them with TPA. Okay. These are just kind of more for your understanding if you're ever on the wards or you're an ED provider along those lines. Then we can use what's called the Pulmonary Embolism Severity Index, right? This helps us kind of gauge the prognosis of our patient. So in the setting of a patient diagnosed with pulmonary embolism, the PESI score can be utilized to determine if he or she is a possible candidate for outpatient management. For those determined to be low risk, a score of 0, the mortality risk is 1.1%. So meaning they can be managed outpatient, right? So we look at the age, right? Are they 80 or below or 80 or above? History of cancer, history of chronic cardiopulmonary disease. What's their heart rate? 110 is the cutoff. What's their systolic blood pressure? 100 is the cutoff. And then their O2 saturation, 90% is the cutoff. So if they have a score of 0, 1.1% risk of mortality, and they'd be a good candidate for outpatient management. So let's put it all together. We have a 58-year-old woman. She presents to the ED with signs and symptoms of pulmonary embolism. The chest x-ray is obtained, which is concerning for right-sided pleural effusion. The admitting physician wants to get a thoracentesis to prove that the pulmonary embolism is the likely cause of this effusion. How should the physician go about doing this? So basically what I'm asking you, right? Pulmonary embolism is a common cause of pleural effusion. How would you go about making the diagnosis that this pleural effusion is likely secondary to the pulmonary embolism? Okay, that's what I'm asking. So take a second and think about it. All right. So essentially, what we're going to need to do is a thoracentesis. Okay. Usually, we need a decent sized effusion, so somewhere above 1 to 2 centimeters of a pocket would be safe. And then when we do this thoracentesis, there's a couple things we need to get. We need to get protein, LDH, cell count, gram stain, culture, cytology, glucose, and pH. Okay. Um, Other things we can get are cholesterol and albumin from the pleural as well, right? What I'm getting at here is you need to understand Light's criteria. So Light's criteria, there's 3 of them. All I need to do is satisfy one of these criteria and we can diagnose an exudative effusion, right? So really simply, there's 2 big flavors of pleural effusion. There's exudative and transudative, okay? There's 3 major mechanisms of edema or fluid where it shouldn't be, right? Which is essentially a pleural effusion, right? There's fluid in the pleural space where it should not be, right? So the 3 major mechanisms of edema are increased hydrostatic pressure, decreased oncotic pressure, or increased capillary permeability, okay? All 3 of those aspects, either by themselves or together, can lead to fluid being where it shouldn't be, right? So with regards to exudative versus transudative, a transudative effusion is secondary to a process that is causing increased hydrostatic pressure or decreased oncotic pressure and/or, right? Sometimes you can have a mix, okay? Exudative is more going to be due to increased capillary permeability. So a transudative process, the major causes of transudative pleural effusion are things like congestive heart failure, cirrhosis, and nephrotic syndrome, okay? Whereas in exudative effusion, major causes are things like pneumonia, malignancy, and pulmonary embolism, right? Pulmonary embolism is such an inflammatory state. We get a lot of vasoplegia, right? A lot of vascular permeability, and we're going to get a lot of leakage out kind of into the pleural space, okay? So pulmonary embolism is almost always an exudative effusion. Super high yield to know, okay? So what I need to do is I need to get my thoracentesis, and I need to determine, is this an exudative effusion? And then just rule out some of the other causes, right? Rule out an underlying infection, rule out underlying cancer, and then we can be fairly certain, okay, this pulmonary embolism is the cause of this exudative effusion, right? So to make that diagnosis of an exudative effusion, we need to satisfy one of Light's criteria. So what are Light's criteria? Their protein in the pleural space is greater than 0.5% of the protein in my serum, okay? If we satisfy that, we're good. The LDH in my pleural space is greater than 0.6 times the LDH in my serum. If we satisfy that, we're good. The LDH in my pleural space is greater than 2/3 the upper limit of normal of my serum LDH, right? So let's say because the serum LDH upper limit of normal changes depending on which lab you're at, right? So let's say at your hospital, your LDH upper limit of normal is like 300, right? So if my LDH in my pleural space is like 250, that's above 2/3, right? 250 divided by 300 would be above 2/3, it would be above 66%. So that satisfies it, okay? So again, I only need one of those to satisfy an exudative effusion, okay? Students get this wrong all the time. I only need one, okay? Other ways we can make a diagnosis of exudative effusion, or at least push me in the direction, we can get the pleural cholesterol. If that pleural cholesterol is greater than 55, or if I take the pleural cholesterol and put it into and divide it by the serum cholesterol, if that's greater than 0.3, that's indicative of an exudative effusion. And I can take the pleural albumin, and if I take the serum albumin minus the pleural albumin, and that's less than 1.2, that indicates exudative as well, okay? Those are more advanced tests. They wouldn't expect you to know those on step 2. You're expected to know Light's criteria, right? We get some of the other things like a gram stain, a cell count with differential, a culture, cytology, to kind of rule out infection and rule out potentially cancer. Obviously, like chest imaging will help on that as well. And then we can get glucose and pH, which are really important for some of my rheumatological diseases like rheumatoid effusion can cause a glucose like less than 20 classically. And then the pH and glucose together can also be really useful for diagnosing an empyema. So empyema, pus in the pleural space that gets loculated, super bad infection. Usually the glucose is quite low and the pH is less than 7.2. Obviously, we'd probably see something on the CTPA. So if we don't see that, right, we can be fairly certain that this is not a empyema. Obviously, using the glucose and pH as well. All right. So if you want to read more, you can take a screenshot of these. This is a JAMA article, an NEJM article, two really good review articles on pulmonary embolism. And if you have questions, please email me, right? But big things for pulmonary embolism, right? Signs and symptoms, right? We got to think about low-grade fever. So it's a huge inflammatory state, right? Increase IL-1, increase IL-6. Those increase prostacyclin E2. They go up to my organum vasculosum in my kind of around the anterior hypothalamus. We bind to the EP3 receptors. Those increase the set point in my anterior hypothalamus and can cause a fever, right? Fever, extremely nonspecific. It's secondary to an inflammatory process, right? Not necessarily an infection. So low-grade fever, dyspnea, tachypnea, tachycardia, pleuritic chest pain, and then probably in the vignette or you talk to your patient, some sort of underlying risk factor, right? Are they older, obese, pregnant, recently started on a contraceptive, recent immobilization, recent surgery, history of malignancy, family history of thrombophilia, right? All things I think about, right? My clinical gestalt is saying, hey, this is a PE. I can do a Wells score, right? If it's above 4, I don't even need to do a D-dimer. Let me start them on unfractionated heparin, get a CTPA, right? I'm not going to do a CTPA if they have really bad contrast-induced allergy, they have really bad kidney function, or they're pregnant. In that case, I'll do a VQ scan. If the Wells score is like 2 or 1 or 3, right? Less than 4, really. I can do what's called the PERC score, which includes 8 different yes or no questions. If we answer yes to any of them, we should get a D-dimer. If that D-dimer is elevated, I should move on with my PE evaluation and do a CTPA and potentially treat them if it comes back positive for an embolus. If the PERC score, everything comes back negative, no need to get a D-dimer, right? And if that D-dimer is low or normal, it's less likely to be a PE, right? Then for treatment, right, if it's a low risk or submassive, we can do anticoagulation with unfractionated heparin. We'll confirm with the CTPA or the VQ scan, right? And then we monitor, right? We can use that PESI score. And if that PESI score comes back at 0, there's only a 1.1% chance of mortality. They'd be a good candidate for outpatient management. If that PESI score comes back, and multiple things we're hitting yes on, then we might want to keep them in the hospital, okay? If they have a massive PE, as defined as hemodynamic instability, so systolic blood pressure less than 90 or a drop in systolic blood pressure by 40 in the span of 15 minutes or more, right, plus right ventricular strain, we have now satisfied massive PE criteria. We should consider systemic thrombolysis as long as they don't have any contraindications. If they do have contraindications, we can do catheter lysis or we can do surgical embolectomy, right? For you future internists, right, it's just always really important that you ask yourself why. Why did this patient have a PE? And you can't tell me, oh, they had a PE because they had a DVT. Obviously, right? That's the most likely. But now, why did they have the DVT? Right? Always ask yourself why. That's the role of a good internist or a family med doc, pediatrician, right? Even an ED physician who's working on a million problems at once. You can always ask yourself why. All right. If you got questions, email me. Otherwise, see you in the next one.